So we're now treating towards ovarian cysts. They are usually asymptomatic, but they may rupture, become hemorrhagic, or lead to adnexal torsion. Um, Adnexal torsion is um, a medical emergency where the ovary and sometimes the fallopian tube twist, cutting off the blood flow and potentially causing death. So, ovarian cysts can lead to adnexal torsion. There are three types of cysts that are discussed here: follicular cyst, functional or physiologic cyst. Most common ovarian mass in young females. It is caused by failure of mature follicle to rupture and ovulate. Caused by failure of mature follicle to rupture and ovulate, it may produce excess estrogen, usually resolves spontaneously. Then there is corpus luteal cyst. It is a functional cyst caused by failure of corpus luteum to involute after ovulation. It may produce excess progesterone and usually resolves spontaneously. So a follicular cyst produces excess estrogen and a corpus luteal cyst produces excess progesterone. And both of them usually resolve spontaneously. The third is a theca lutein cyst, which is also known as hyperreactive lutein nearis, caused by HCG overstimulation, often bilateral or multiple, associated with gestational trophoblastic disease, example, hydatidform mole or choliocarcinoma. So, yeah, we discussed the fecal lutein cyst in the complications for choliocarcinoma, and it is also known as hyperreactive lutein and it is caused by HCG overstimulation, and it is often bilateral or multiple cyst in the ovary, and it is associated with gestational trophoblastic disease. Moving on to ovarian tumors, which is a very interesting topic. Most common adnexal mass in the females um, greater than 55 years old. It is present with abdominal distension, bowel obstruction, and pleural effusion. So the abdomen will be distended, the bowels will be obstructed, and the pleura will be effused. And it is the most common adnexal mass in females older than 55 years of age. Um, Risk is increased with advanced age, increased number of lifetime ovulations. If there is an early menarche or a late menopause and nulliparity, it causes increased ovulations, and increased ovulations can lead to ovarian tumor. Endometriosis, genetic predisposition, example BRCA1 and BRCA2 mutations, or Lynch syndrome. I'd like to see what is Lynch syndrome. Okay, so it is a genetic condition that raises the risk of many types of cancer, especially colon cancer and endometrial cancer. All right. So colorectal, the most common cancers in Lynch syndrome are colorectal, stomach, pancreas, urinary tract, and ovarian uterine cancer in females. So BRCA1 and BRCA2 mutations and Lynch syndrome are the genetic predisposition to ovarian tumors. The risk decreases with previous pregnancy, history of breastfeeding, OCPs, and tubal ligation. Okay, so ovarian tumors have factors that increase the risk, and then there are factors that decrease the risk, including breastfeeding, previous pregnancy, OCPs, and tubal ligation. Epithelial tumors are typically serous. Okay, so I'd like to, with the help of this diagram, I'd like to say that the ovary has a surface epithelium, and then this is the egg, and this egg has a follicle, and there is the cortex or stoma of the ovary. So from the surface epithelium arise epithelial tumors. From the follicle and the egg or the gamete arise the germ cell tumors, and from the follicle and the cortex or the stoma arise sex cord stromal tumors. So the epithelial tumors are typically serous, that is, they're lined by serous epithelium natively found in fallopian tubes and often bilateral, or they're mucinous. So epithelial tumors have two types, serous and mucinous. The mucinous is lined by mucinous epithelium natively found in the cervix. Monitored response to therapy or relapse by measuring CA 125 levels, which is not good for screening, but it is important for monitoring the response or relapse. Germ cell tumors can differentiate into somatic structures. So the pathology or the mechanism behind germ cell tumors is that they are classified according to the different fetal components that germ cells can form. So they might develop into somatic structures, example teratomas, or extraembryonic structures, example yolk sac tumors, which are also known as endodermal sinus tumors, or they can remain undifferentiated, example dysgerminoma. Um, and there was another type of tumor which I have seemed to forgotten, but yeah, teratomas, yolk sac tumors, and dysgerminomas are all types of germ cell tumors. Sex cord stromal tumors develop from embryonic sex cord, develops into theca and granulosa cells of the follicle, circli and leading cells of semiaphus tubules, and stromal, which are ovarian cortex derivatives. So theca and granulosa cells, certainly leading cells, and stromal, which are ovarian cortex derivatives. These are all sex cord stromal tumors. Now, epithelial tumors, types and characteristics. The first is serous cyst adenoma. It is benign, most common ovarian neoplasm, and it is lined by fallopian tube-like epithelium because, again, it is serous, and the serous epithelium arises from natively from fallopian tubes. The mucinous cyst adenoma is benign, multiloculated, and large. It is lined by mucus-secreting epithelium. So, yes, this is the mucus secreting epithelium that is lining the mucinous cyst adenoma, a mucinous cyst. Then there is Brenner tumor, which is usually benign. Nests of urothelial-like, bladder-like epithelium with coffee bean nuclei. Okay, this is a very important point to remember that the Brenner tumor is going to be like bladder or epithelium with coffee bean nuclei. How I usually remember is from Dr. Bruce Banner, who plays Hulk in the MCU, and he's kind of green, so green is associated with bladder, and it is associated with coffee bean nuclei. Or so Dr. Bruce Banner is just having some coffee, and it is usually benign. Now, serous carcinoma is the most common malignant ovarian neoplasm. Serous cyst adenoma was the most common um, benign ovarian neoplasm, and serous carcinoma is the most common malignant ovarian neoplasm, and it has some bodies. And mucinous carcinoma is malignant. It is rare. It may be metastasis from appendiceal or other GI tumors, can result in pseudomyxoma peritoniae, which is intraperitoneal accumulation of mucinous material, also known as omental caking. So, pseudomyxoma peritoniae. Mucin producing cancer cells fill the abdominal cavity, most commonly originating from the appendix. Um, so yeah, this is a normal appendix, and this is appendix mucinous neoplasm, and rupture appendix mucinous neoplasm causes excessive compression of abdominal and pelvic organs, and with surgery you have to remove all this mucinous. So a mucinous carcinoma can cause a pseudomyxoma peritoniae, which is excessive mucinous secretions all over the peritoneum, and it is malignant. And most common malignant ovarian neoplasm has to be serous carcinoma, and most common ovarian neoplasm, which is benign, has to be serous cyst adenoma. Then there are germ cell tumors that arise from the germ cell. They include mature cystic teratoma, also called dermoid cyst. It is benign. It is most common ovarian tumor in young females. Uh, okay. Okay, it is in young females, it is the most common cystic mass with elements from all three germ layers, teeth, hair, sebum, may be painful secondary to ovarian enlargement or torsion. Monodermal form with thyroid tissue. Stroma ovuli may present with hyperthyroidism. Malignant transformations are rare, usually it is common cell carcinoma. Okay. So there's a lot of information in these lines, primarily being that a mature cystic teratoma is called dermatoid cyst and it is benign. It really is malignant, and even if it is malignant, it develops into squamous cell carcinoma. And it has the elements from all three germ layers. A teratoma is a very, wait, first see the diagrams here. So yeah, this is a teratoma. It has hair, it has um, skin, it has teeth, I suppose, it has sebum, it has different tissues. that can arise. And it may be painful secondary to ovarian enlargement or torsion, and it has a monodermal form with thyroid tissue, which is known as struma ovariae. So, struma ovariae is the condition in which there is let's just search it. Struma ovariae related to it is a rare ovarian tumor predominantly composed of thyroid tissue, usually benign but occasionally malignant. Okay, so struma ovariae is a condition in which in the ovaries there is thyroid tissue, and that is the monodermal form of mature cystic teratoma, also known as a dermoid cyst. An immature teratoma is malignant, it is aggressive, it contains fetal tissue, neuroectoderm, commonly diagnosed before age 20, typically presented by immature or embryonic-like neural tissue. So basically, if a teratoma is malignant, aggressive, and has neuroectoderm in it, then it is an immature teratoma. If it has multiple tissues, it is a dermoid cyst or a mature cystic teratoma, and also a monodermal form of mature cystic teratoma would be monodermal form with thyroid tissue, which is known as struma ovariae. And in the malignant transformations for mature cystic teratoma are rare, but the immature teratoma is malignant. Then there is dysgerminoma, which is malignant. It is most common in adolescents, equivalent to male seminoma, but it is rarer than male seminoma. There are sheets of uniform fried egg cells, tumor markers that increase in HCG and increase in LDH. And increase in LDH is a very important tumor marker for remembering dysgerminoma. So it says um, D, right? Fried egg cells. So these are the fried egg cells, which are characteristic of dysgerminoma. Then there's yolk sac tumor, also called endodermal sinus tumor. It is malignant and aggressive. It is yellow, friable hemorrhagic mass. 50% has scalar dual bodies that resemble glomeruli. And the tumor marker is an increased alpha fetoprotein because yolk sac produces alpha fetoprotein. So yolk sac tumor will produce increased AFPs as well. It occurs in children and young females. So SAC, S for scalar dual bodies, A for AFPs, and C for children. And that is a scalar dual body. That is glomerulus-like. This could be considered the Moment's space, and this could be the Moment's capsule, and these are the glomeruli. So that's why they are called a glomerular-like structure. So far we have done epithelial tumors, in which serous acidinoma is the most common ovarian neoplasm, and serous carcinoma is the most common malignant ovarian neoplasm. Mucinous carcinoma can produce pseudomyxoma peritonei, and the only malignant in these epithelial tumors are serous and mucinous. Germ cell tumors are mostly malignant, except mature cystic teratoma, which is also known as dermoid cyst, which is benign, and the monodermal form is known as stroma ovariae. Dysgerminoma is characterized by LDH increase and fried egg cells, and yolk cell tumors are characterized by scalar dual bodies, increased AFPs, and children and young adult female presentation. Now come the sex-coed stromal tumors. The first is fibroma, which is benign, bundle of spindle-shaped fibroblasts. Mead syndrome, which is a very important triad, is a triad of ovarian fibroma, ascites, and pleural effusion. Pulling sensation in the groin. If the fibroma presents with ascites and pleural effusion, and there's also a pulling sensation in the groin, it is known as Mead syndrome. I'd like to see a picture of the Meads syndrome, if there is any. There isn't any classical presentation, but the person will have basically ascites on the CXR and pleural effusion as well. Then comes a thecoma, which is mostly benign. It may produce estrogen. It usually presents as abnormal uterine bleeding in a postmenopausal woman. Female. So it produces estrogen because theca cells produce estrogen. Then there's a certainly Leydig cell tumor that is benign. It is gray to yellow-brown mass that resembles testicular histology with seminiferous tubules lined by Sertoli cells and surrounded by interstitial Leydig cells, and may produce androgens that causes virilization. Example, hirsutism, androgenetic alopecia, and clitoral enlargement. So what we have to remember is that there's a gray to yellow brown mass. There is increased secretion of androgens, which causes testicular histology and virilization, with symptoms such as hirsutism, androgenetic alopecia, and clitoral enlargement. Then there is a granulosa cell tumor, which is the most common malignant sex-cord stromal tumor, and it predominantly occurs in females in their 50s. Often produces estrogen or progesterone, presents with postmenopausal bleeding, endometrial hyperplasia, sexual precocity in pre-adolescents, um, breast tenderness. Histology shows Paul Exner bodies, granulosa cell arranged haphazardly around collections of eosinophilic fluid resembling primordial follicles. Um, Figure would be an increased inhibin and give granny a call. So gran and call Exner bodies. These are called Exner bodies. They are granulosa cells that are arranged haphazardly around collections of eosinophilic fluid. They resemble primordial follicles, and tumor markers an increase in inhibin. So for sex cord tumors, we have for fibroma, the important thing is Meek syndrome, that is pulling sensation. For sarcoma, estrogen is in abundance. For sickly Leydig cell tumor, androgens are in abundance, and for granulosa cell tumor, there is an increased inhibin. So these are some important markers to remember for these respective tumors. Moving on to uterine conditions, they are classified into non-neoplastic and neoplastic. The non-neoplastic first one is adenomyosis, which is the presence of endometrial tissue, glands, and stroma in the myometrium. It may be due to invagination of basal layer of endometrium or metaplasia of remnant progenitor cells. So adenomyosis, adene shows that it has to do something with the glands, and meiosis shows that it has to do something with the myometrium, is the presence of endometrial tissue in the myometrium. And it has the causes that the basal layer of the endometrium invaginates into the myometrium, or it could be due to metaplasia of remnant progenitor cells. It presents with abnormal uterine bleeding, dysmenorrhea, diffusely enlarged, globular, soft, boggy uterus on exam. Then comes endometriosis. It is the presence of endometrial tissue outside of the uterus. So adenomyosis with endometrial tissue inside the myometrium, which is inside the uterus, and it had a globular, soft, boggy uterus on exam. But endometriosis is the presence of endometrial tissue outside of the uterus. And it may be due to ectopic implantation by retrograde menses, lymphatics, or blood vessels, or metaplasia of remnant progenitor cells. Same as an adenomyosis, it presents with dysmenorrhea, dyspareunia, which is discomfort during sexual intercourse, infertility, abnormal uterine bleeding. Physical exam is usually normal. However, findings may include immobile uterus, adnexal mass, uterosacral tenderness, or nodularity, but are non-diagnostic. So the uterus does not move in endometriosis. There is adnexal mass, the uterosacral tenderness or nodularity, and they are all non-diagnostic. It typically involves pelvic sites such as superficial peritoneum, yellow-brown powder-burn lesions, and ovaries form blood-filled chocolate cyst called endometrioma. So when the endometrial tissue goes to implant on the ovaries and there's continuous shedding of the endometrium, it forms blood-filled chocolate cysts, which are called endometrioma on the ovaries. And in the superficial peritoneum and pelvic sites, it causes yellow-brown powder-burn lesions. So these are the yellow-brown powder-burn lesions that are very characteristic of endometriosis. And they have not shown the chocolate cyst, have they? But the chocolate cyst in the ovaries, endometriosis, are an important link. They look somewhat like they're only animations in them. Yeah, but they look like this. It looks like chocolate on the ovaries. This is a sign of endometriosis. And moreover, the important points here are that it could be due to ectopic implantation by retrograde menses, lymphatics, or blood vessels, and the findings include an immobile uterus, adnexal mass, uterosacral tenderness, and the all of these are non-diagnostic, but it involves the pelvic sides and ovaries, causing a yellow-brown powder burn lesion or chocolate cyst. Then comes endometrial hyperplasia. It is abnormal endometrial gland proliferation. It usually caused by excess estrogen unopposed by progesterone. It is associated with obesity. We've already discussed this estrogen unopposed by progesterone because I think we discussed that mm, endometrial hyperplasia could be caused by some ovarian condition or uh, right here. A follicular cyst could progress to excess estrogen and cause increased risk of I'm not really. It was somewhere up there. Yes, increased risk of endometrial carcinoma because of PCOS due to unimposed estrogen. So unimposed estrogen can cause a lot of endometrial conditions. The first one being an endometrial hyperplasia because there's no progesterone associated with obesity, chronic anovulation, example PCOS, nulliparity, HRT, and tamoxifen. HRT is a hormone replacement therapy, and tamoxifen is a pharmacologic drug that is used against breast cancer. But it has this condition in which it causes the inhibition of breast cancer tissue, but it causes um, mm, pro-estrogen effects on the endometrial tissue, and thus it causes endometrial hyperplasia. It presents with abnormal uterine bleeding, as in all the conditions related to endometrium. Increased risk of endometrial carcinoma, especially with nuclear atypia. If there's a nuclear atypia, then it increases the risk for endometrial carcinoma. And the important thing to remember is that it is caused by unimposed estrogen increase, which can be due to obesity, PCOS, nulliparity, HRT, and tamoxifen. Then there's endometritis, which is the inflammation of endometrium. It usually occurs after delivery due to inoculation of uterine cavity by vaginal microbiota. So it is a condition in which there is inflammation, and it occurs after delivery in which the vaginal microbiota or the bacteria invade the uterine cavity and cause inflammation there. C-section is the most important risk factor. Sutures and necrotic tissue act as a nidus for polymicrobial infection, and it presents with fever, uterine tenderness, and purulent lochia. What is lochia? Lochia. Okay, so it is postpartum vaginal discharge, alokia. Intrauterine adhesions are fibrous bands or tissues within endometrial cavity. They are caused by damage to basal layer of endometrium, usually after dilation and cartilage. Um, they present with abnormal uterine bleeding, decreased menses, infertility, recurrent pregnancy loss, dysmenorrhea, also called Asherman syndrome when symptomatic. This is very important. Intrauterine bleeding or Asherman syndrome. The symptoms of Asherman syndrome include uh, firstly, there's fibrosis and adhesions of the endometrium, may also include the myometrium. And then the symptoms appear as in this diagram. There is first there's painful menstrual period, then there's irregular menstrual cycles, and there's light or absent menstrual periods, then there's difficulty getting pregnant, repeated miscarriages, pelvic pain, especially during sexual intercourse or menstruation, and then there's unusual or abnormal uterine bleeding between the periods. So it is a very painful condition, Asherman syndrome, because of fibrous bands in the endometrial cavity. So for non-neoplastic conditions, we studied adenomyosis, which is the presence of endometrial tissue inside the myometrium, endometriosis, which is the presence of endometrial tissue outside the uterus, and it presents with an immobile uterus, adnexal mass, uterosector tenderness, and all of these are non-diagnostic, but it also has powder burn lesions in the peritoneum and chocolate cysts in the ovary. We next have endometrial hyperplasia, which is due to unopposed secretion of estrogen as compared to progesterone, and it causes an increased risk for endometrial carcinoma. Then we have endometritis, which is because of a C-section or delivery that causes the bacteria from the vagina to enter the uterine cavity, and this causes inflammation. Next, we have intrauterine adhesions, which can develop into Asherman syndrome when they are symptomatic. The neoplastic conditions include leiomyoma and endometrial carcinoma. So, a leiomyoma or a fibroid is a benign tumor of the myometrium, also called fibroid. Most common gynecological tumor. It is the most common gynecological tumor overall. It arises in reproductive age females. There's an increased incidence in Black population, typically multiple subtypes based on location. It may be submucosal, intramural, or subserosal. It is usually asymptomatic but may present with abnormal uterine bleeding, pelvic pressure or pain, because it is going to be a large mass, and reproductive dysfunction. It is estrogen sensitive. The tumor size increases with pregnancy and decreases with menopause. There's an enlarged uterus with nodular contour on exam. Um, this the uterus is enlarged and there's going to be a nodular contour because these are the nodules that are present in that fibroid mass. The histology would be whorled pattern of smooth muscle bundles and well demarcated bodies. Well demarcated bodies. These are the whorl, like this is a whorl pattern of smooth muscle bundle of the uterus, and there is a well demarcated body. This one is very important, especially because it is benign tumor of myometrium and it has location submucosal, intramural, or subserosal, and it is the most common gynecological tumor. However, it is present in reproductive age females, unlike many of the tumors that are present in postmenopausal women. And the incidence is increased in Black population. It is usually asymptomatic, but there's going to be a uterine bleeding, pelvic pressure, and it is estrogen sensitive tumor with increased where there's an increase in size with pregnancy and decrease with menopause. Then there is endometrial carcinoma, which is the malignant tumor of endometrium, most common gynecological cancer in resource-rich countries, usually arises in postmenopausal females, presents with abnormal uterine bleeding. Endometrioid carcinoma is the most common subtype of endometrial carcinoma. It is associated with long-term exposure to unopposed estrogen. Unopposed estrogen everywhere there is an endometrial condition. The histology is confluent endometrial glands without intervening stroma. So these are all the glands, they're very confluent and they do not have any intervening stroma. And it is the most common gynecological cancer in resource-rich countries, but it is related to endometrium, and leiomyoma is related to tumor of the myometrium. And it arises in postmenopausal women by, while leiomyoma would be in reproductive age females. Next is breast pathology. Okay, so we'll touch onto some of it, and because it is a vast topic, so we'll touch on some of it. So these are the breasts. Within the breast, this is the stroma of the breast, this blue area, and this is the terminal duct lobular unit, which is also known as the functional unit of the breast. This is the lactiferous duct, and this is the nipple. The There are different conditions related to each of these part. The stroma corresponds to fibroadenoma or phylloides tumor. The terminal duct lobular unit, which is the functional unit of the breast, is associated with fibrocystic change, BCIS, LCIS, ductal carcinoma, and lobular carcinoma. We'll see what these are. Lactiferous duct is associated with intraductal papilloma, abscess or mastitis, memory duct ectasia, and Paget's disease. So let's dive into it. First of all, there are benign breast diseases, and then there are malignant or other diseases. So the benign breast diseases are the first is fibrocystic change, then there are inflammatory processes, benign tumors, and gynecomastia. All right. So most common in premenopausal females, 20 to 50 years old, is fibrocystic change, presents with premenstrual breast pain or lumps, often bilateral and multifocal. There's going to be premenstrual breast pain or lumps. Non-proliferative lesion include simple cysts, fluid-filled duct dilation, blue dome, papillary apocrine change or metaplasia, and stromal fibrosis. Risk of cancer is usually not increasing. Proliferative lesions include sclerosing adenosis and epithelial hyperplasia. These are a lot of heavy words, and we try to simplify them. Fibrocystic change is a change in the terminal duct lobular unit. This portion, this is the terminal duct, and it is a unit of this whole lobule. All right. So it has a fibrocystic change where there are going to be lumps which are bilateral and multifocal, and the simple cysts are going to be fluid-filled cystic dilations in which the size of this area increases, and they present as a blue dome on the breast. And papillary or apocrine changes or metaplasia is also possible. So apocrine change is a change in the glands in this unit, which would cause a papillary appearance on the examination, and a metaplasia of this area can also induce fibrocystic change. Moreover, there could be stromal fibrosis. This area could undergo fibrosis that could result in a fibrocystic change in this area. And the risk of cancer is usually not increased. So there are three kind of lesions that are non-proliferative in this region. The first, including simple cysts, in which there is a dilatation of this duct, and it presents as a blue dome. The second is going to be papillary apocrine change, in which there is a change in the gland or metaplasia, and the third is going to be stromal fibrosis, and there's no increased risk of proliferation. Now, these are all non-proliferative lesions. I'll repeat again. They are simple cystic lesions. They are lesions that include papillary apocrine changes, and the third one are those that include stromal fibrosis. Now, the proliferative lesions include sclerosing adenosis, in which acini and the stromal fibrosis occurs associated with calcifications. There's slightly increased risk of cancer. The non-proliferative lesions are basically those lesions in which the benign cells do not invade the basement membrane of the breast. But the proliferative lesions are those in which there is an invasion of the basement membrane of the breast, and these include sclerosing adenosis and again epithelial hyperplasia. So sclerosing adenosis is that the acini and the stroma undergo fibrosis, and it is associated with calcifications. There is slightly an increased risk for cancer, and epithelial hyperplasia cells in the terminal duct or lobular epithelium are affected, and this increased risk of carcinoma of atypical cells. I think there would be it would be easier if there is a pictorial description of it. So this is normal breast tissue, and this is sclerosing adenosis. It is a palpable mass, a radiologic density or calcification, in which the number of acini per terminal duct increased to double the number found in uninvolved lobules. So normal lobular arrangement is maintained, but the acini are compressed and distorted in the central portions of the lesion and characteristically dilated at the periphery, and the myoepithelial cells are prominent. So the breast tissue is composed of an epithelium, and below that there is the myoepithelial cells. There are lobular cells, and then there are myoepithelial cells, I suppose. And in this region, the acini per terminal duct are increased, and this causes this is what we call sclerosing adenosis. Another picture would show it as this is a mammogram. There is calcification shown on the mammogram, and there's microcalcification right here in this one. Microcalcifications are present in less than 50% or greater than 50% of the cases and may be prominent, and they're usually numerous, fine texture delegated within the sclerosed acinar. There's an increase in number of acini per duct, and there are going to be calcifications in sclerosing adenosis. And this says it has acini and stromal fibrosis associated with calcification and slightly increases for cancer. Then there's epithelial hyperplasia. Cells in the terminal ductal or lobular epithelium are affected, and it causes and increased risk of carcinoma with atypical cells. So all of these are fibrocystic changes. There are non-proliferative fibrocystic lesions in which there are simple cysts, papillary or apocrine changes, and stromal fibrosis. And there are proliferative lesions in which there is sclerosing adenosis and epithelial hyperplasia. In the inflammatory processes, there is fat necrosis, which is benign, usually painless lump due to injury to breast tissue. It is a calcified oil cyst on mammography. So there's an oil cyst on mammography. Necrotic fat because it is fat necrosis and giant cells on biopsy. Up to 50% of patients may not report trauma. Patients do not remember the trauma there because they do not recall it. They might not call it trauma, but it is actually trauma, and so they do not have a recollection of it in their memory. And this would cause fat necrosis and giant cells and necrotic fat on biopsy and calcified oil cyst. Then there is lactational mastitis, which occurs during breastfeeding. It increases the risk of bacterial infection through cracks in the nipple. Staph aureus is the most common pathogen for it, and it is treated with antibiotics and continued breastfeeding. Then there's mammary duct ectasia, which is dilatation of subareolar ducts with inflammation and fibrosis, associated with smoking, presents with areolar pain, multicolored discharge, inverted nipple, and periareolar mass. So there's going to be a mass, and the subareolar ducts are inflamed, and it is associated with smoking. So far, we have discussed benign conditions with fibrocystic changes, in which there are 5 conditions, including 3 non-proliferative and 2 proliferative conditions, inflammatory conditions involving fat necrosis, lactational mastitis, and mammary duct ectasia. Now we're going to benign tumors, which involve fibroadenoma, intraductal papilloma, and phylloides tumor. So fibroadenoma occurs in the stroma, along with phylloides tumor, and intraductal papilloma occurs in the lactiferous duct. So these are all benign conditions that are occurring right here. And let's discuss what they are. So fibroadenoma is most common in females less than 35 years of age. They're small, well-defined mobile mass. Tumor is composed of fibrous tissue and glands. Increased size and tenderness with increased estrogen, example pregnancy prior to menstruation. Risk of cancer is usually not increased in fibroadenomas. So the location is important. That is the tumor composed of fibrous tissue and glands, and it is a mobile mass which is sensitive to estrogen, and in the size and tenderness increases with increased estrogen, example in pregnancy or prior to menstruation. Then there's intraductal papilloma, which is a small fibroepithelial tumor within lactiferous ducts, typically beneath areola. So intraductal papilloma occurs here in the lactiferous ducts. The location is important. It is typically beneath areola and is the most common cause of nipple discharge, often unilateral, serous, or bloody, and there's slightly increased risk of cancer. Phylloides tumor is a large mass of connective tissue and cyst with leaf-like lobulations. Leaf-like is important. It is most common in 5th decade, okay, and some may become malignant. So it says A. I think A is right here, yeah. So it is a large mass of connective tissue and cyst with leaf-like lobulations. It is going to be a mass of connective tissue and cyst with leaf-like lobulations, and it is going to be important in 5th decade. So these are all benign cases. Now, gynecomastia is breast enlargement in males due to increased estrogen compared with androgen activity, physiologic in newborn, pubertal, and older males, but it may persist after puberty. Other causes include cirrhosis, hypogonadism, example in Klinefelter syndrome, testicular tumors, and drugs such as spironolactone. These are the causes of gynecomastia, which is the breast enlargement in males. So all of these were benign conditions related to breast. Again, we discussed fibrocystic changes that occur in terminal duct lobular unit, and these include non-proliferative conditions, which are simple cysts or apocrine papillary changes and stromal fibrosis, and proliferative conditions including sclerosing adenosis and epithelial hyperplasia of the terminal ducts. And then we discussed some inflammatory processes, including fat necrosis and lactational mastitis and mammary duct ectasia. And benign tumors include fibroadenoma, intraductal papilloma, and phylloides tumor. And gynecomastia is the condition with this breast enlargement in males. We'll discuss breast cancer in the next video, as this one is going to be very enlarged.